Okay, I'll turn it over to Dr. Selberg, and we'll talk about some pathology. Go ahead.
Sure. I want to start, because as you walk around the trade show, you're going to see a couple different technologies out there. One is some cone beam, and one is the fan beam like this one here is. And so they have distinct advantages over their current configurations, but there's a couple things. For instance, this one not going to get a standing neck into the caudal aspect of the neck in the standing patient, but anesthetized, obviously, some of the other ones that are configured, you can get caudal neck. And we have both at Colorado State to compare and contrast both technologies, fan beam versus cone beam. And so this is a fan beam which tends to show our bone, but our soft tissues a bit better than our cone beam. And our cone beam is a little bit limited by the physics currently in seeing the soft tissues. And also our cone beam tends not to be able to use Hounsfield units, which is a differentiator in our soft tissues. So for instance, if I'm looking at fluid within the soft tissues versus a solid structure, that's a different differential diagnosis, and that is important to consider when looking at the two different technologies. And that can be in a skull. So if we're looking at let's say a late age horse that you're wondering whether it's a dental origin or a neoplastic origin, that's going to be a real challenge to differentiate on the cone beam CT versus our fan beam CT. So the ultimate, though, you're going to get a soft tissue sample to diagnose the disease process anyways. But your list of differential diagnoses open up a fair amount when you're looking at the two different technologies. I want to start with ultimately kind of the sexy portion of this, which is the caudal aspect of the neck. And what we're finding more and more when we look at these necks, specifically in doing myelograms, is that our myelograms, our standard myelograms, are potentially underestimating, and we've kind of surmised this is happening for quite a number of years, underestimating what is actually compressive and then what is actually compressing the spinal cord. And a lot of people like to do measurements, and a radiologist with a ruler in hand is a radiologist in trouble. That's always true, but what we're understanding is that, the mid-sagittal diameters that we tend to use for looking for cervical vertebral malformation or even narrowing of our subarachnoid space on our myelograms potentially can even underestimate where our stenotic areas are. And there's great research out of Rudenriddle, specifically, where they look at the spinal cord area versus the subarachnoid space area and looking for areas that are narrowed. And if we follow this horse down, I'm going to do a multiplanar reconstructed image real quickly, just to give people an overview of what is where we're at on the neck. So as we look at this specific neck right here, you can see we're in the caudal cervical spine. C6 is coming down, large kind of plate of bone along the lateral aspect. And as we look at the contrast, specifically, as we look at the transverse images, we follow the subarachnoid space sitting right here. And as we start to come right over the top of the more normal area right here, large subarachnoid space, moving down into a more narrowed subarachnoid space, you can see the percent area of the subarachnoid space versus the spinal cord narrows a fair amount. And we're learning more and more about what is happening at this particular area. So it can be bony stenosis, we can have soft tissue, and more recently we had a nice soft tissue compression from lateral compression from the capsule coming in, and so that might change what you're going to do clinically. So is this going to respond to intra-articular medication, or are we going to have to do something more drastic in a horse that has a stenotic or dynamic compression, so spinal cord or spinal canal fusion kind of thing versus intra-articular medication, to see if we can get that horse more comfortable. And the myelograms have been instrumental. We can also see morphologic changes very, very nicely within the dorsal articulations, so the articular processes as we move more caudally. And as we see in this one, we have a very nice area of bony stenosis as we move through, larger articular facets, and we can see the lateralizing narrowing sitting right here as we move down. And so some of that is bony stenosis, but there's also a soft tissue component that comes in along the more lateral aspect of the spinal canal and narrows the subarachnoid space. And we can see that sitting right down here a little bit more. And all of those things as a perfect storm will contribute to our narrowing. This lateral compression is not going to be, you're just not going to see that in your standard myelographic studies. And so this is a huge advantage in looking for areas, and there's a lot of times that myelograms are equivocal in their findings. So one side versus another side, and we're not just necessarily going to see that particular area on our standard myelograms, and we're going to have to look at our CT myelograms. And they're making we're understanding more and more about what is happening in our pathologic change with our caudal cervical spine specifically, with our CT technology. And this is giving very, very nice resolution between our soft tissues as well as our bones. So very nice trabecular bone. We're starting to see our soft tissues coming in here a little bit better. And notice that the contrast shows up very nicely. In this technology, we do see that very nicely in our myelograms and our cone beam technology as well. But as I move on to another study in, let's say, the distal limb, and they had mentioned doing contrast, arterial contrast associated with the distal limb. And that is important to think about because in the cone beam technology, we don't tend to be able to see that intra-arterial contrast very well. The scatter tends to eliminate it, and we don't see that as well as we'd hope. And that is important because if you're going to use this and you don't have another technology to look at our soft tissues, let's say MRI, or it's in an area that is not seen by ultrasound, and this is a technology that you have is CT, then your arterial phase contrast is going to be very helpful to rim around the areas of tearing within the deep digital flexor tendon in areas that are difficult to see ultrasonographically. And we're just not going to be able to see that well. And we've tried several times with our cone beam CT to look at those areas with intra-arterial contrast in some futile nature. But intrasynovial structures we can see very well. We can put contrast within the distal interphalangeal joint, the fetlock joint, and look for surface abrasions within our patients that we take to CT, but we're not going to see those intrasubstance cartilage lesions in the CT patient. So just a difference in a little bit of looking at MR versus CT, and that's not really what we're here for. We're really just looking at CT, and we can see that this is never going to be seen with our ultrasound. It sits more lateral. Those can be very challenging to see, and looking through the transcranial region on ultrasound, and this really is going to be the application in the distal extremity, looking for distal margin or distal aspect of the deep digital flexor tendon tears. So very nice lesion here. If we see those kind of lesions in the CT, we can then opt to treat those, especially with some of our stall stride treatment options that we have. We can do a quick PRP run and put our biologic in there into the deep digital flexor tendon using CT guidance, and those are pretty easy to do under general anesthesia for sure. Is there any questions as far as I move through here about some of our pathologic change or the differences between some of our CT technologies? I see a couple of big guns that are sitting over here at this table of imagers. No? Quiet? Okay. So as we look at these, we can definitely see the areas in the distal limb. And then we think about, Dr. Potenza showed a nice study or talked about proximal suspensory ligament. And that is another area that I think is important because as we know more and more about the proximal suspensory ligament area, there's a variety of pathologic changes that occur in that proximal aspect of the suspensory ligament. And we know that ultrasonographically we're getting much better at looking this area, and we're knowing by comparison images from our ultrasound, also our CT, we're getting better at diagnosing small minutiae on ultrasound. But there's definitely areas that are a bit of a challenge to diagnose. And so because it's a limited acoustic window, some ultrasound technologies are better than others, and so it depends on what you have. But the CT itself shows a very nice global overview. And if we look here, we can see very nice bone. And so we see this nice endosteosclerosis. We see this huge exostosis coming out and circling around the suspensory ligament, coming down and around. The one thing we're not going to see on CT is we're not going to see bone fluid, and that's a disadvantage a little bit in terms of figuring out some of the diagnosis. And some of these horses will have their major component of their diagnosis will be bone fluid within the proximal aspect of the third metatarsus bone, but we're going to get a reasonable identification of some of the soft tissues. And so as I look at this is a bone window, and one of the key features that we look at is also bone, but we also want to have a nice soft tissue window. And we can see that there's going to be a difference in what things are going to look like. And we definitely have to window level each one of these to look for our soft tissues. So now as we start to look at this, and this is an arterial face, and window level this a bit, and now we can start to see our soft tissue differentiate. So superficial, deep digital flexor tendon, here's our suspensory ligament. We start to see these black areas, which are muscle fat fiber definition between in the suspensory ligament, and that's important to look at too as we look it through here. And then the diffuse somewhat enlargement of the suspensory ligament as we move through. So this is an important area, especially in areas that, let's say, this is outside of a comfort level for certain people, depending on what happens in their practice. The CT will help out. And now that is, you get the CT, you get to go back and look at ultrasound too and compare those. And this modality will up your game in terms of looking at areas of pathologic change in a variety of areas using ultrasound and CT. And so the other area that, and we went over this yesterday a little bit in some of the table topic, but the tarsus and proximal aspect of the suspensory ligament are a challenging area because there's oftentimes overlapping areas of pathologic change. And so they oftentimes will occur in some unison where you have disease in the tarsus, but also disease in the proximal aspect of the suspensory ligament. And so when we look at this, we can see now a nice global overview of looking at, and there's a little bit of motion in this, but the machine tends to motion correct, but we can see some of our joint margins very well, and we can see that there's very little pathologic change associated with our distal tarsus. And almost all of the pathologic change is occurring within the proximal aspect of our suspensory ligament. And so we can be a little bit more confident in focusing our diagnosis and our treatment to one particular area versus having to spread it out and treat a couple different areas. And this area can be somewhat refractory to treatment, right? And so that may be because we didn't get the right diagnosis in its entirety or a partial diagnosis. And so giving this nice global overview of the proximal aspect of the suspensory ligament is important to get the horses back and working. 2 minutes. With that, I'll give any questions. No, none at all. You can find me afterwards. I'll hang out here if you guys have specific questions you guys want to grab.
Dr. Nick, you have a question about what's the limitation on being able to do stifle horses?
For stifles, is that the question?
Right.
It's just purely your table and your positioning. So up to your mid-sized quarter horses, the positioning's fairly straightforward. Beyond that, you have to be able to put them on their back with their stifle extended. And so that just becomes a bit of a tabling issue because you have to have a certain portion of the horse off of the table. So that's just something for larger horses. We haven't really broached that yet.
Any other logistical questions? Okay, we have to get out of here, and I'm actually going to drive this back to the sound booth over there in 1087, so if you want to see the logistics of it being moved, then feel free. Otherwise, thanks for coming. I appreciate it, and have a good one.